So today we're going to be talking about malabsorption syndrome. Malabsorption syndrome goes on about the defect in the absorption of nutrients, both macro and micro. Many symptoms differ depending on the nutrient that isn't being absorbed. The common nutrients that we can test for would be fat, carbohydrates, B12, folic acid, and iron. Fat malabsorption, most commonly seen otherwise in pancreatic insufficiency, can be tested using a 24-hour fecal fat test. A more efficient test is the trialine test, and that's the current recommendation for preliminary screening. There are multiple tests to check for carb malabsorption. Stool test is usually used to identify reducing substances and is commonly used in children. The stool ends up having a decreased pH level caused by the carbohydrate fermentation. D-xylose, a type of sugar, is easily absorbed in the intestine, so this test measures the level of it in blood or in a urine sample. And a breath H2 test checks for sugar intolerance. B12 is used in the body for a lot of processes and is important to ensure a healthy level in a person. B12 absorption occurs in the terminal ileum. You can test it by checking for the serum B12 levels. From biochemistry, there are two enzymatic reactions that are dependent on B12. The first reaction has methylmalonic acid converted into succinyl-CoA using B12 as a cofactor. In the second reaction, homocysteine is converted into methanoin using B12 and folic acid. So a deficiency in B12 would lead to a serum increase of methylmalonic acid and homocysteine levels, and that would be a good indication for B12 deficiency. Now, the textbook method is to use Schilling's test, although we don't use it these days. It is essentially a procedure that tests for the detection of radiocobalt-labeled vitamin B12 in the urine. Folic acid, commonly absorbed in the jejunum, is measured with the FIGLU test. This 4-miminoglutamic acid test measures the folic acid nutritional status. Iron absorption occurs through the DMT1 transporter in the duodenum, and an S-ferritin test, amongst other tests, will give you the amount of iron stored in the body. So now that we know how to test these nutritions, the three most common malabsorption syndromes are the celiac disease, the tropical sprue, and the Whipple's disease. Let's look through this one by one. The celiac disease is an autoimmune condition triggered by the dietary gluten peptides. The disease peaks in two incidences, in infancy or in an adult above 50 years of age. So the clinical presentation is usually in a very small child. Up to 6 months old, babies are breastfed. So all the patients that come in with suspected celiac disease would be above 6 months old because that is when they're introduced to solid food. So if this child is allergic to gluten, what happens? Physiologically, there's an increased production of antibodies against the gluten, which ends up damaging the microvilli, and that ends up reducing the absorptive surface area of the gut. And this will give you three classical histologic features. The first one is villous atrophy, which leads to a reduced absorptive surface area. You also have crypt hyperplasia, meaning there's an increased cellular proliferation, and an inflammatory infiltration, with an increase in intraepithelial lymphocytes and an influx in immune cells into the lamina propria. The villous atrophy eventually leads to a decreased sugar absorption, and with osmosis, water gets drawn along it too. This leads us to our first clinical symptom, osmotic diarrhea. Patients with osmotic diarrhea usually have watery stools and respond to fasting. The damage in multiple areas of the small intestine cause a variety of symptoms. The duodenal damage, which is the most damage, decreases the overall absorption. The jejunal damage leads to a reduced folic acid, and the ileum damage reduces the B12 absorption. Some patients can have a decreased iron manifesting as delayed motor reflexes in their child. Other than this, identifying extraintestinal manifestations also help with the diagnosis. So the first one is that the child will usually have anemia, and this is caused by the malabsorption of iron and folate, so you would get a mix of megablastic and microcytic anemia. The other clinical manifestation is osteoporosis. There could be a variety of untreated reasons, but in this case, the malabsorption of calcium and vitamin D can cause it. The third and the key clinical presentation for most children is that they have dermatitis herpetiformis. This is a blistering condition and is strongly associated with celiac disease. They have rashes that is intensely pruritic, as in there's a lot of pus, and these vesicular eruptions usually occur in their elbows and are extremely itchy. So for screening, a small bowel imaging is done as it can help assess for complications such as lymphoma. A barium imaging or a capsule endoscopy can be done. An upper GI biopsy is taken mostly to demonstrate the flattening of the villi. Patients should also be tested for the presence of autoantibodies, such as IgA anti-tissue transglutaminase and IgA anti-endomysial antibodies. They are not always present, so a patient with a positive serological test should be referred for upper GI endoscopy and intestinal biopsy for the 3 histological features mentioned earlier. The first biggest complication is dermatitis herpetiformis. This is tested with a skin biopsy and an IgA level. So on histology, you would see a linear IgA deposit on the derma papillae. It's then treated with dapsone. The second biggest complication is lymphoma. You should consider the association of lymphoma with this case if the patient has an unresponsive treatment or unexplained clinical features. So amongst these screening tests, biopsy is the investigation of choice. So for treatment, a patient goes under strict dietary restriction for 4 weeks, after which they should redo the biopsy to check for the regeneration of the damaged villi. You should also give an iron supplementation that deals with microcytic anemia and folic acid supplementation that deals with macrocytic anemia. Tropical sprues have a similar manifestation with celiac disease, that is, they have malabsorption and flattened villi, but with slight variations. This type of malabsorption syndrome is caused by a bacteria such as Giardia or E. coli. The malabsorption is primarily of carbs, causing an osmotic diarrhea through the same mechanism we discussed earlier. Fat absorption leads to diarrhea that has fat content, bulky and foul smelling. There is also significant weight loss along with muscle wasting. The decrease of fat absorption can cause secondary malabsorption of fat-soluble vitamins. So you have a vitamin A deficiency that causes nyctalopia, the inability to see in dim light or at night. Vitamin D deficiency will end up with bone pain or osteomalacia, known as softening of the bones, which is troublesome if the patient is young as it can lead to easy fractures. A vitamin E deficiency causes ataxia, which is a degenerative nervous system disease. The presentations are basically like of those being drunk, and is caused by a damage to the cerebellum. Vitamin K deficiency can lead to bleeds and purpuras. So again, with this disease, the investigation of choice is biopsy along with the identification of the bacteria's presence. Treatment is with tetracycline and folic acid. Whipple's disease is a systemic disease most likely caused by gram-positive bacterium, Trophermia whippeli. It's caused by an intracellular bacteria, unlike tropical sprue, which is caused by an extracellular bacteria. Clinical experience with this disorder is rare. The pathophysiology is similar to the other malabsorptive diseases, with the distribution of damaged villi function. However, along with the small intestine involvement, the disease also affects the joints, the CNS, and the cardiovascular system. So with malabsorption, you would get osmotic diarrhea, which is responsive to fasting, and steatorrhea. When the CNS is involved, they exhibit dementia-like signs. This reversible dementia is caused by niacin deficiency. Remember, niacin deficiency is manifested as the 3 Ds: diarrhea, dermatitis, and dementia. So look out for any of these. Although not seen very often, cardiac involvement is a very important clinical sign. Most cases it's due to an aortic valve stenosis, but this can manifest as murmurs or an insufficiency or endocarditis-like symptoms. So it's key to keep this in mind when thinking of differentials. So biopsy is done for this disease too. You will get the characteristic tissue changes with the rest of the syndromes. To differentiate it, you have to detect the bacteria by staining the macrophages. Other studies can be done like a fecal test or an imaging study, although they aren't really specific for the Whipple disease. Histological findings will be helpful with supporting the diagnosis. So the standard treatment for this disease is to start off with IV ceftriaxone for 2 weeks minimum and follow up with oral co-trimozazole, which is a combination of trimethoprim and sulfamethoxazole for 1 year. And that's the end of discussion for malabsorption syndromes. Thank you for watching.